Hello, my name's Deirdre Tim and I'm a dietetic intern for Oakwood University. Today I'm here to present on my nutritional case study, which is on well-differentiated squamous cell carcinoma. So it is a type of cancer, but through this presentation I will be commonly referring to it as WSCC. So some definitions about WSCC. So essentially it is, again, a type of cancer. According to Cunliffe et al., it is a type of skin cancer arising from the keratinocytes of the epidermis. So the epidermis is a layer of skin, and the keratinocytes are what become cancerous. And it is the second most common type of skin cancer. So when we talk about normal organ function, so the affected area with many people with WSCC is head and neck. With our case study person today, they ended up having a growth on their neck, and the cancer was on their tongue. So that has significantly impacted many normal functions for him in terms of swallowing, chewing, and even carbohydrate digestion. As we know from Escott Stump and Nelms, which I am citing in this presentation, the salivary glands basically break down the carbohydrate sources, and that's where digestion for the absorption of carbohydrate sources begins, is in the mouth. For protein and fats, it doesn't occur until later on in the digestive tract. But for head and neck patients, especially with WSCC, their ability to absorb carbohydrate sources is limited. So that is how it differentiates from normal organ function. And for many people that have WSCC, when it affects their head and neck, it can limit their ability to obviously ingest foods and obtain enough nutrients to prevent malnutrition. And we'll kind of go over that a little bit more later on in the presentation. Okay, so in terms of the pathophysiology, along with some nutritional implications. So basically, just with normal cancer, the pathophysiology is basically the same. There's a three-step process, and this includes the initiation, the promotion, and then the progression. So in terms of the initiation, so that has to do essentially with many times like lifestyle habits that we might do that essentially are going to produce carcinogens. And these carcinogens have the capability, I guess, to go into cells and to change some of the DNA components that are in the cells. And by doing that, it can promote a faster reproduction of cells, which is essentially how the cancer starts. So some of these lifestyle habits that we could do that would create what we call initiators would be like tobacco smoking or over sun exposure, even some different cooking styles, even some foods that you could eat or things like that can help make these initiators that initiate the process of cancer formation. So then the second stage then is these promoters. So then promoters are many times things that we don't necessarily have as much of control over. These could include things like hormones, our gender, demographics, genetics plays a big role, and even just our health status. And when I say health status, what I mean is our immune function. And so when our immune function is lower, it leaves our body a little bit more open to having cancer be able to come in and take over, certain areas or certain functions of our body. And so when we are able to keep our immune function up, then this can lower our risk factors for cancer. So the initiators, the promoters, and then the progression. So in terms of progression, when it comes to cancer, there are 4 stages of cancer, and depending on when the cancer is first diagnosed, can determine the prognosis and types of treatment that are going to be available. If you're only in stage 1, then it means that the cancer is localized to one area and hasn't necessarily metastasized and spread to the lymph nodes and other areas of the body. However, when you get to stage 4, then this means that the cancer has metastasized to other areas, and it's a lot harder to treat because there's more area that is going to have to be treated. So that essentially is just in a nutshell the pathophysiology of cancer. When we talk about nutritional implications of cancer, so again, there are certain food items that we can eat that are going to have more of an influence of carrying more carcinogens, but on the other end, there are foods that we can eat that are going to help with our immune function by just giving us more of the phytochemicals that we need, and some of those are going to be in our fruits and our vegetables and things of that nature. So that's why a lot of times dietitians will tell people to eat a variety of fruits and vegetables of different colors because there's different phytochemicals in the different fruits and vegetables, and they can have, not that they're going to prevent cancer, but they might lower risk factors for cancer. And then again, so then there are things, food sources that we can eat that are going to have more carcinogens in them and are going to increase our risk factors for cancer. So obviously, those are things that we kind of want to avoid if possible. And then in terms of treatment for cancer, there are, so when a person might be being treated for cancer through chemotherapy or radiation, there are going to be drugs in the chemotherapy that can cause adverse effects and some side effects, I guess. And these side effects can sometimes inhibit a person's desire to consume certain food items, or it can also affect lab values and increase risk factors for malnutrition or anemia and things of that nature. And also, when radiation is targeted at certain areas, it can kind of limit the already debilitating function of certain areas. So sometimes it is appropriate to have nutritional support, especially for head and neck patients, because there's so much treatment happening, in the ingestion area of the body, and when that gets kind of worked on, then that can make it harder to take things orally and might require parenteral or enteral nutrition. So in terms of the etiology, when we talk about WSCC, the 2 most common cited etiologies, according to Nelms et al., are tobacco smoking and sun exposure, which, is common for some types of skin cancer, that would be, that those would be the major etiologies. But in terms of just general cancer development, genetic susceptibility can be a very strong etiology, as well as some of those lifestyle habits that we do. And again, the lifestyle habits a lot of times are what initiates the cancer development, and then the genetic susceptibility, or our age or gender and our demographics, are a lot of times the things that then promote from the initiation. So in terms of symptoms and clinical manifestations, according to Nelms et al., a lot of times the first indications of cancer are the presence of a tumor in an area, so like a growth of cancer cells in an area that we first notice that just doesn't look right. Many times that'll be what kind of prompts getting tested for cancer. But also could also be when we notice that our immune system is kind of lowering down, and this could mean that we just feel a little bit more tired or have just a natural malaise or feel kind of anemic for a while, or have a bleed maybe that doesn't quite go away right away, or just keeps coming back, and we just notice that our body just isn't as strong as it could be. Sometimes those are indications of of checking to see whether or not there is a spot of cancer in an area. For our case study person, he first noticed a lump on his neck, and then realized that when he went in, then he was diagnosed with WSCC of the tongue. And so the growth had metastasized to another area, which was how he got tested. But actually, he had begun having his cancer 6 months before he first went in to have his diagnosis. And at that point, he had actually lost some weight, which is actually quite common for head and neck cancer patients. Okay. And some of the symptoms then that are common are related a lot of times to the chemotherapy drugs, and these could include some nausea, vomiting, diarrhea, constipation. For our patient in specific, he, with his cancer treatment, has also suffered with difficulty swallowing, dysphagia, xerostomia, severe weight loss, malnutrition, and anemia. So nutritional interventions for WSCC are pretty common for, as a general intervention for cancer, but the Nutritional Care Manual has a lot of good resources in terms of interventions. And some of the biggest interventions that they recommend for cancer patients would be to increase your calorie and protein intake, and that just helps with preventing some of that weight loss that's commonly seen. And then also taking nutritional supplements to just kind of help supplement some of those nutrients that might be being lost because of the target of what the treatment is. For head and neck cancer patients, and especially with our case study patient with WSCC, he had difficulty swallowing and difficulty taking things orally. So having a nutritional supplement was great because it gave him calories, extra calories that he needed, but it didn't require him to have to chew, and swallowing was kind of minimal too, and it was in a liquid form, so then that is a little bit easier on him. And then the last thing that they recommend is just to manage symptoms of chemotherapy. So sometimes a person that's going through chemo might have a lot of nausea. So finding the kinds of foods that are going to kind of reduce the nausea, or maybe it's eating at specific times or doing specific things before or after you eat to just kind of help manage those symptoms. That's another key part of maintaining good nutrition during cancer treatment. Okay, so now that we have done a little background about WSCC, we can get into who our case study individual is and a little bit more about the case study person. Okay, so our case study is a 50-year-old Caucasian male. He was first diagnosed with his malignant neoplasm of WSCC in May of this year. And his usual body weight is 75 kilograms, but today he is 57 kilograms, which is a 25% weight loss. And his usual body weight is also his ideal body weight, just as a reference as we're going on through the case study. His height is 5'10", and that puts him at a BMI of 17.9, which is considered to be underweight. So how has cancer affected him personally? As I kind of mentioned earlier, because of where his cancer is located, it has affected his ability to swallow because it's on his tongue. And so then this has made him not as willing or able to take things orally. which has resulted in a decreased intake. And he, upon initial assessment, then indicated that he was not really eating any solid foods, mostly liquids, and just kind of had a lot of anorexia or loss of appetite due to not being able to really eat anything due to pain and swallowing difficulties and things of that nature. And subsequently, that also resulted in a 30-pound weight loss in 6 months, which was 19%. So from when he was first noticed his cancer started to when he was finally diagnosed, that was a 6-month stretch, and he had lost 30 pounds in that time period, unintentional weight loss. So in terms of social history, our case study used to be a teacher. He worked in a high school, but he acquired too many sick days because of just symptoms of not being able to eat and the progression of his cancer. And so he recently quit his job when he began full-time chemotherapy and radiation treatments. On a personal note, he is a father of 2, although he does not have custody of his kids, and he is a divorcee. So his parents are the major support system that he has, and they have attended many of his inpatient admissions and also his outpatient radiation and chemotherapy treatment that he receives 3 to 5 times a week. And upon initial assessment with our case study, he had indicated that he had been a smoker for 25 plus years, and that he also commonly drank about 36 plus alcoholic drinks a week. So our case study patient has been readmitted to the hospital many times, and most of the readmission reasons for him have been related to some of his side effects from his chemotherapy, and some of the medical conditions that have arisen or complications that have arisen from his inpatient stays have been post-procedural pneumothorax, acute kidney disease, dehydration, anemia, and malnutrition. And this has subsequently resulted in him needing 100% of his EEN, or his estimated energy needs, to be provided from enteral nutrition. So in terms of his surgical and medical history, so his surgical history is actually pretty limited. He had a tonsillectomy when he was 4, and then he also had a fix on his left index finger tendon 2 years ago following a motorcycle accident. And his family history does include some cancer. His maternal grandmother had some cancer, and his paternal grandfather had some cancer, but he also has a paternal uncle that has diabetes. Okay, so here, and I know you can't really see on the screen, which is why I'm including a copy of this PowerPoint to follow along with. But on this screen, we have lab values that were taken from one of his earlier admissions. And some of the things to note are the irregular values in his electrolytes. So he has some abnormalities in his sodium, his potassium, his albumin, his BUN, his creatinine, his globulin, and his glucose. And we're going to kind of go over what all those abnormalities are indicative of, and also what a normal range would be. And then this next screen too is just indicates a couple more abnormality lab values. So this is his red blood cells, his HGB, or his hemoglobin, and his HCT, or his hematocrit. Okay, so on this screen here, I have the different lab values that were shown to be irregular per his lab tests. And then I also have what the normal range would be, what a high value would indicate, what a low value would indicate, and then what his values actually were and some of the dietary implications. So just as a quick thing here, many of his values that are irregular are actually very close to normal range. So it's not likely that it's indicative of anything chronic. It's more of an acute condition. And these actually match up very nicely to the side effects of his chemotherapy that are the reasons for his admission. They all line up pretty well with that. The one thing I will note here, and when you are looking at your PowerPoint handout here, is that the creatinine level on his lab value was indicated to be out of normal range because it was a 0.6. However, according to Pronsky et al., the normal range for creatinine is actually 0.4 to 1.2. So within the 0.6, that would be considered to be a normal range. However, based on different facilities, sometimes they have more stringent ranges on some of their lab values, and it is considered irregular at different places. However, at a different facility, it might not have been considered an irregular value. So some of the most common dietary implications of the irregular lab values here are medication interaction, infection, dehydration, malnutrition, and then anemia. So physical data, there's a whole host of physical data available. I did not include much physical data just because the patient has been in outpatient cancer treatment 3 to 5 times a week for the past 8 months. And then he's also had over 5 inpatient admissions since diagnosis. So it would be a lot of information to get through. So instead I have, and as you'll see when I kind of go over the nutrition care plan for him, I have included 5 of his most unique care plans that have been used. After a certain point, his admissions became very similar to each other, and the diagnoses were all the same, and the interventions were pretty much all the same as well. So I didn't include all of those admissions just because it would be a little redundant to kind of go through the same thing. So I have picked 5 of his most unique cases. So just to highlight some of the physical data, what would be apparent on there would be some weight loss, which I will go over in just a couple slides here. And then, so his BMI initially when he was first diagnosed was at 19.4, which still considered him in a normal range. It was on the lower end of normal BMI. However, as he began to lose even more weight, he ended up at a 17.9, which is considered underweight and increases risk factors for malnutrition. We already kind of went over some of those irregular lab values that were seen from one of his earlier admissions. However, other admissions once he was started on tube feeding included irregular values consistent with refeeding syndrome. So then that kind of prompted more attention to make sure that his rate wasn't too high and to make sure that he was handling his tube feeding solution well. And then also his iron level and his protein level were also have commonly been low in other lab values, which was pretty consistent with anemia, which he was diagnosed with later. So here on this screen that you can't really see, but we have a list of medications that he is taking outpatient. Just to highlight a couple, he's on a 2-cal tube feeding formula, and then he's also on nutritional supplements of Boost. So that's just like a commercial beverage. And then he's also on magnesium oxide and potassium chloride that he receives through his PEG, and that is likely to kind of help with some of those deficiencies that might come about from medication interactions of his chemotherapy, and could also have to do with his lab values perhaps being low, maybe just because he's not consuming enough of those nutrients, but also just probably likely because of his medications kind of stripping the stores of certain nutrients. And speaking of which, this screen here shows the different chemotherapy drugs that he has been on throughout his 8-month battle with cancer. All of the chemotherapy medications obviously are anti-neoplastic drugs, and they all have different dietary implications. Many of them are that they're commonly going to produce side effects of nausea, vomiting, diarrhea. There's also some of the drugs that he's taking that make him more at risk for malnutrition, anemia, weight loss. And then each of the drugs that he's taking in some way affect certain lab values that he's taken or that he has, which could be that they might increase the lab value or that it might decrease, especially in terms of vitamins and minerals, that some of those stores might be stripped by taking the chemotherapy drugs. And yeah, so let's see here. So in terms of diagnostic tests, there are not a lot of diagnostic tests that the case study patient received inpatient. Many of his admissions have been very straightforward. They've commonly been for many of the same kinds of things and have been most of a direct result from the side effects of his chemotherapy treatment and his radiation treatment. So it hasn't presented with anything abnormal. But some of these diagnostic tests that he has had have been chest x-ray, because they were trying to insert a PEG tube and he experienced a pneumothorax. And then also he has commonly had blood and urine tests that have been taken almost every day that he's been there, just to monitor his lab values. Again, with the tube feeding, they have been concerned about refeeding syndromes, so the magnesium, the phosphorus, the calcium, those types of labs have been looked at just to make sure that he is tolerating his tube feeding well. But then also, as his admissions have progressed, anemia has also been an issue that he has struggled with, so then checking his protein and his iron has been important as well. Okay, so here on the screen that you can't really see, I have his medical treatment / his treatment goals. So there's a lot of information in terms of his outpatient status and his inpatient status. But some things that I just kind of wanted to highlight were that so a month after he was first diagnosed, he began receiving nutritional support for 100% of his estimated energy needs, or his EENs. And then a month after that, he started another round of chemotherapy. And this included the docetaxel, the cisplatin, the 5-fluorouracil. And at this point, so he had started, so in June of 2018, he began receiving the tube feeding. However, a month later, it was changed to a different type of tube feeding. And then a month after that, he was admitted to the hospital due to being like in a neutropenic state and was having some complications from the chemotherapy. And this is when his pneumothorax occurred. And so it took, a couple days here to be able to actually put the PEG tube in to be able to give him enteral nutrition because with the pneumothorax, and they weren't able to get in to place the PEG tube. So at the end of his admission at that point, he was again changed to a different solution for his tube feeding, the 2-cal, which is currently what he's on as well. And a month after that admission, then he started another chemotherapy with the paclitaxel and the carboplatin. And just a week later, he ended up in the hospital again for an inpatient due to, again, being in a neutropenic state. And at that point, he was shown, like a tube feeding regimen for taking it at home because they determined that he was going to need just extra help with his tube feedings. And so I'm going to kind of go over this more with the nutrition care plan, but a lot of the reasons for changing his tube feeding formula were because throughout his treatment, he has continued to lose weight. When he started his treatment, he had lost that 30 pounds, which was about 19% of his weight loss. And then it continued to a point, so now he has actually lost 25% of his weight, which is not great, especially when it comes to cancer treatment, and you're already kind of losing weight a lot of times. So that was a large reason for changing the formula. And then also he, as we'll see going over the nutrition care plan, he had some risk factors for malnutrition and actually was diagnosed with malnutrition at one point. And so that, again, kind of prompted the need to change formulas and to do things a little differently. So in terms of the nutritional assessment, so the next couple slides that we're going to go over are going to be in relation to the nutrition care plan. So that would be the assessment, the diagnosis, the intervention, and then the monitoring and evaluation. When we talk about the diagnosis, intervention, monitoring, and evaluation, I am going to kind of go over that in a little different way. So again, as I kind of mentioned earlier, I picked 5 of his most unique admissions. And so what I'm going to kind of do is go from the first diagnosis, intervention, monitoring, and evaluation. And I'm going to kind of highlight what the main points were. And then as we go on to the next one, we'll kind of see what the changes were as we go from the second diagnosis to the third, to the fourth, to the fifth. But first we'll start off with the assessment, which when I talk about the assessment, this is the initial assessment when he was first diagnosed. And again, when he first came to have, and he had his cancer diagnosis, he reported that he hadn't been eating a whole lot because he had some difficulty swallowing and some pain with chewing and things like that because of the cancer on his tongue. And so his intake of normal food items was pretty much limited to just liquids. But before his cancer diagnosis, he had reported that he ate a diet high in protein, high in some simple sugars. He really liked his sweets and his, like white flour-based products. He also, as he had already mentioned, commonly drank about 36 alcoholic drinks a week. And his intake of fruits and vegetables was actually pretty limited, according to him. He's not a big fruit and vegetable kind of person. He just, can't really find a fruit or a vegetable that he's too fond of without putting many different additives onto it. And then the last thing was that he commonly drank many different commercial beverages of sugar-sweetened beverages like sodas, juices, things like that. So in terms of his MNT education, he reported not having had any previous education. According to his medical history, he has not really had problems with his health before the cancer diagnosis, and so he never really saw a need to go see a dietitian for any reason. And he did not report to have any allergies. Okay, so first here, which can't really see, but we have anthropometrics, and so this lovely white table here kind of just goes over his weights early on in his early on in his cancer diagnosis. As we can kind of see here, since knowing that his usual body weight was 75 kilograms, from here it's pretty much a median of about 55 kilograms. So we can kind of see that there's about a 20 kilogram weight loss at this point, which is very significant, especially since this individual is a smaller, guy. He already kind of started off on the lower end of BMI, and now he's underweight. His height, again, is 5'10", or 177.5 centimeters. And because of his weight loss, he, at this point, is 75% of his ideal body weight, which is also his usual body weight of 75 kilograms. And then this slide here just also kind of goes over just a little bit more of his more recent weight values, and there's still pretty much that 55, 56 kilogram. There are a little bit of variations, but they all kind of stay between 55 and 58 kilograms, so it's stayed pretty consistent, but definitely there's a big drop from initial to where he is now. So, in determining his energy requirements, I use the nutritional guidelines from Aspen, which is from August et al., and then also Basola's Interventions of Head and Neck Cancer Patients, to determine his energy needs, which are 30 to 35 kcals per kilogram. So that amounts to about 1,700 to 2,000 calories per day. Then his protein needs are 1.2 to 1.5 grams per kilogram of his ideal body weight, which then is taking that to 75 kilograms. And so then that amounts to 90 to 113 grams. And then his fluid needs are 1 milliliter per 1 kcal. So then again, that's that 1,700 to 2,000 milliliters. Okay, so now we're kind of getting into the nutrition care plan. So we're starting, very soon after he is diagnosed. The date that I have here is May 31st. And again, his diagnosis came somewhere in May. Probably right around this time here. So the first diagnosis that he got for his condition was inadequate intake related to swallowing difficulties, decreased appetite, pain secondary to new diagnosis of cancer. And then this is as evidenced by eating minimal solid foods, weight loss of 30 pounds or 19% over 6 months. So this is stuff that we've already kind of talked about. So as he's kind of going into his outpatient to begin his treatments, this is what they're noticing. He's not eating a whole lot, and this has kind of prompted his weight loss. And this is all kind of due to not being able to swallow things and having pain. And so it makes sense. In terms of the interventions that they suggested at that time, the dietitian suggested at that time, was basically focusing on eating high calorie, high protein food items, because they will kind of help keep his weight up, especially since he had had some weight loss. Then this was super important to just help him maintain. And then also they encouraged him to take nutrition supplements, and that's kind of referring to Boost or Ensure, things like that, that are going to be easier for him to take in calories, but aren't really going to require much from his oral cavity. So it's not going to really require him to have to chew anything or anything like that, or even produce saliva to break it down. It's just going to be an easy swallow for him. In terms of monitoring and evaluation, the big thing that they wanted to keep in mind was to to like limit his weight loss, since he'd already lost so much weight coming into his cancer diagnosis that they didn't want him to lose any more weight. And at that time, they had talked with him about starting tube feeding just to help with a little bit of providing him some extra nutrition, since he was not able to take things orally very well. And so they gave him some handouts on peg tube placements, and also just how to add calories and protein extra to things without making him have to swallow or chew things more. So that's just kind of adding different condiments and things to some of the liquid products that he already ate, just to kind of keep his nutrition up. Okay, so then his next diagnosis is from a month after that. And the main difference is at this point is that he is now actually diagnosed with malnutrition. He has lost even more weight from his first diagnosis. He has also, because of the weight loss, has also had some noted muscle loss. And because he has been able to take even less orally, this is when they started him on the peg tube full-time, so that it would reach 100% of his EENs. And then what they also did at that time was give him information about how to do his tube feeding at home. And so then there was information about how to administer the solution and how to clean everything, so that he could go home with his solution and be successful. So interventions at this point were, if he's able to take anything orally, they wanted him to have like a honey thickened consistency, and they wanted to promote him to take things orally if he'd be able to, but they were providing the tube feeding for him to meet 100% of his needs, to make sure that he doesn't lose any more weight. And at this time, they were doing them in a continuous feed of 55 milliliters an hour. And he was on the 1.5 kcal solution with fiber. And then monitoring and evaluation at this time didn't focus as much on weight loss, but more just making sure that he knew how to use his tube feeding correctly, and to make sure that his body was tolerating the tube feeding correctly. And as with all of his monitoring and evaluations, if he had questions, he was advised to contact the registered dietitian for some more information and for guidance. Now, the third diagnosis came a month later. From this one, the diagnosis switches back to an inadequate intake, so that malnutrition status is not used in this diagnosis. However, we do see that he has a continued weight loss of 4 kilograms. And at this time, he doesn't just have difficulty swallowing, but he's also starting to kind of deal with some of the side effects of his chemotherapy. So he's reporting nausea, vomiting, diarrhea, and that is affecting his desire to take nutrition, whether it's enterally or orally. So this is just really causing a lot of issues for him. So then at this time, so he had been on the 1.5 kcal with fiber, and so at this point they moved him. The patient kind of just desired that he wanted to try some different formulas, so they actually had him on 3 different enteral nutrition formulas that he could buy on his own. And each one of the formulas that he was taking were 237 milliliters. And so out of the 3 that he took, he would take 1 to 2 of each a day, and those would be his feeds. So instead of taking the continuous feed, he moved to having bolus feeds 6 times a day. And the monitoring and evaluation, because he had lost some more weight, moved back to focusing on trying not to lose any more weight, and trying to kind of build some of that muscle mass back a little bit. And again, if he had any questions about some of his new tube feeding here with his bolus feeds, he was advised to contact the dietitian. Now we have our fourth diagnosis here, and this is altered GI function is the main etiology here. And so just a little background on this admission is that at this point the patient had started his chemotherapy, and then within like a week later he's in for like a neutropenic state. So he comes in with a fever, he's having profuse vomiting, diarrhea. He's not handling the chemotherapy very well. And so because of that, we see that the diagnosis then focuses on the GI distress, not necessarily on his inadequate intake or his malnutrition that's seen in his other diagnoses. And again, he's still receiving 100% of his EENs from enteral nutrition. So then at this point, his tube feeding solution changes again to the 2-cal. So instead of taking those 3 that he had been taking, now he's just taking 1, and it is a 2-cal, which provides pretty much the most caloric value that you can have in a solution. And this was just to make sure that he really doesn't lose any more weight, and really just make sure that he's getting as many nutrients as possible in as little formula as possible. And so again, he continued with the bolus feeds 6 times a day, but instead of having the 3, then he just had the 1. And at this time, because of everything that had kind of changed, they re-educated him on home tube feeding, and just helped him understand the new formula that he would be taking, and encouraged to contact the dietitian again if he had any questions. Okay, so that is it for the nutrition care plan. I'm sorry, I know that I had mentioned that there was going to be 5, but I guess there's just 4. So my apologies. So kind of wrapping up here, but a requirement of the case study was to do a sample menu. However, for this patient, it would not be applicable to have an oral sample menu because of his inability to swallow and whatnot. However, if he had been, in some of the earlier stages of his cancer, or if he had a different kind of cancer, again, some of the things that I had mentioned as cited from the nutrition care manual, that would be important tips to include on the menu, would be focusing on having higher calorie and higher protein food options to maintain weight and nutritional status. Also, making sure to incorporate as many fruits and vegetables of different colors and varieties to just get as many phytochemicals as possible to kind of just help, with the immune system and whatnot, and just to kind of help keep the body as healthy as possible. And then also, because as we saw with our case study patient, having GI distress is very common when going through chemotherapy. It is important to have fiber-rich sources. So then this just kind of helps with the GI system. And then also meets our RDA for different vitamins and minerals. So our last source here the last slide here that you can't really see very well is my resource slide. So I know that I didn't mention all of these sources within the PowerPoint. However, as I will attach here as well, in the actual written case study, which is goes into further detail of some of these things, these sources were used to just kind of help add add clarification for certain things and to add validity to what I put. So I know that I don't have anybody here to actually answer questions for, but I am going to, I recorded this so that my preceptors could watch it and they can give me questions to answer later. So I thank you for your time here in watching this presentation. I know it was a bit long and I kind of rambled, but I hope that this has been informative, And thank you very much.